Hey there, I am Dr. Monica Minger, and I am so glad you're joining me today. I'm going to be chatting all about fertility. So, maybe you're here because you're working to try and get pregnant. Maybe you've been struggling with fertility issues for a while. Maybe you've been told that IVF or IUI is your only option, and that's why you're here because you don't want to go that route, or maybe you've tried that and it's not going as well as expected. Or maybe you just have some additional questions and want to learn more about what other options are out there. No matter what the reason you're here, you are bound to find some answers here. And I am so excited to be able to share with you a little bit different approach rather than just conventional medicine when it comes to managing and understanding why fertility issues may exist, as well as what we can do to work forward. So let's get started. So, I wanted to start a little bit just talking a little bit about myself. So, I am Dr. Monica Minger. I am a family medicine physician by background, and I've been practicing in the Cedar Rapids, Iowa area for about the last 12 years. Now, in addition to my medical training and background with regular family medicine residency, I have received some additional training specifically in women's health and fertility. And that's going to be in a few different methods listed here. So, the Creighton model or NAPRO technology, FEM medical management, as well as neofertility medical management. And about in August of 2023, I actually founded Radiant Clinic, and all we manage all day long is all women's health concerns, specifically in relationship to menstrual cycle abnormalities, as well as fertility concerns. So I'm very excited to share this information with you today because I'm incredibly passionate about getting this education out to women and really just helping them to understand that there are better ways forward and that oftentimes we're not presented all of the options that are out there. So here's another approach. So, I wanted to start off just with a few fertility facts. And so, eventually, as we kind of go through, we're going to answer these questions along the process, but wanted to start with a very common misconception. And that is that evaluation from a medical standpoint should start only if I've been trying for more than 1 year. And in my world, this is false. A lot of times mainstream medicine will say, go and try to get pregnant for the next year. And if you're having troubles, then it's time to come and get evaluated. In general, is female factor more common? Now, oftentimes we think there's a lot more that goes on with women's health from a hormone standpoint. Things are fluctuating and changing. And so oftentimes people will think that the female factor is more common than male factors. Now, this might be true. And often what we find is that it's about equal as far as how often we find male factors. And more importantly, we need to be looking to make sure that we're evaluating both factors together because sometimes both partners will have an issue with their fertility. Fertility issues affect 1 in 6 couples. Now, this is true, and this is a worldwide statistic. And so, when we look all across the world, 1 in 6 couples will be impacted by fertility sometime along their lifetime. Now, this may be primary infertility, meaning I have a hard time getting pregnant in the first place. This may include recurrent miscarriages or not being able to carry to full term, or this may be termed secondary infertility, which we'll talk about in a little bit here. But in general, 1 in 6 couples will experience fertility concerns. And the other one here is that does fertility problems mean that I have to do IUI or IVF? I was told this is my only option. And this is a big false. And this is part of the reason why it's so important for me to talk to you today, because we have another way forward here that is not involving of artificial reproductive technologies and really gets to the root cause of what may be happening with your fertility. So just a few disclaimers here for my legal people. All of the names, data, and charts have been de-identified. So I am going to be sharing some real data with you today, but some of them has been changed so that we can protect the privacy of our patient that I'm sharing her case with today. The information that I present here today does not substitute medical advice, and so it's incredibly important that you work with a licensed healthcare professional for appropriate evaluation and treatment recommendations customized to your unique needs. Even if you have similar situations as to what's going on with this case I'm going to present today, it does not necessarily mean that the supplements, medications, and lifestyle changes are going to be the right fit for you. So let's jump in, and I'm going to start off with a story about a past client of mine, and we'll call her Kay. Now, Kay came to see me when she was about 37 years old. She had never been pregnant before. 4 years prior to this, when she was about 33 and a half, she actually stopped the birth control pill because she wanted to try and achieve pregnancy. She had went to her OB and her OB said, go ahead, go and try to get pregnant for a year. Come back and see me if you have troubles. And so a year later, she did end up back at her OB's office and the OB said, well, let's try some Clomid. I'll check a couple labs. Everything looks normal. So we'll try the Clomid for the next 6 months. And so Kay said, okay, this must be what I need to do. So she took the Clomid medication for the next 6 months. Unfortunately, she had some significant side effects. She had a couple cycles that things were actually overstimulated and she developed some ovarian cysts. Over the course of that time frame, she ended up spending about $500 out of pocket in regards to both the medication she was taking as well as the office visits. Throughout this time frame, unfortunately, she did not achieve a pregnancy. So her OB then referred her on to IUI, or intrauterine insemination. Now, she and her husband went through 4 rounds of IUI over the course of the next 4 rounds for 6 months. They did not achieve a pregnancy during any of this time either, and they ended up spending about $1,800 out of pocket. Well, since the Clomid didn't work and the IUI didn't work, her OB said, look, last ditch option, the only thing I have to offer you is IVF. And so she was then sent on to IVF, or in vitro fertilization. Over the course of the next 6 months, they went through 3 rounds of IVF where she had egg retrieval as well as implantation. She did have 1 positive pregnancy test, but she unfortunately miscarried about a week later. The other 2 rounds did not result in a successful pregnancy or implantation. Over the course of that 6 months, her out-of-pocket cost was nearly $45,000, and she still did not achieve a full-term pregnancy with this. So all in all, from the time that she stopped the birth control pill, 30 months later, she still had no baby. They had spent over $47,000 out of pocket. She had some significant side effects from the medication, and most importantly, she was emotionally exhausted, frustrated, and overwhelmed because she had gone through all of these steps. She did everything she was told to do, and she was given a diagnosis of unexplained infertility. So why did all of these things fail? You know, we're always told that medications, IUI, IVF, this is the magic answer for everything when it comes to fertility. And really, there's a couple different pieces that went into play with Kay's case. First of all, there was no true diagnosis that was made as to why she was having fertility troubles. Yes, she had some preliminary labs done. Yes, she had some ultrasound testing done. Yes, her husband had a seminal fluid analysis done, but they were basically told everything was normal throughout the time, and so there was no real reason why they couldn't get pregnant. If she didn't have a diagnosis, it meant that there was no way to target treatment because there was nothing that was being worked on from a cycle-to-cycle basis. And so really what was trying to happen with these meds and with these artificial reproductive technologies is that they were trying to force implantation and hormone stabilization. And the way this is often done is that they're given mega doses of hormones and ovulation stimulation. And this is oftentimes why we hear that women are told you can't be on this ovulation stimulation medication for longer than 6 months. We don't want to hyperstimulate or overstimulate because we can have some significant side effects. The underlying factors in Kay's situation for ovulation and implantation were not evaluated, and thus they were not able to be corrected. Nobody really addressed her lifestyle changes along the way. She looked like she was a fairly normal weight, healthy individual, and so nobody did any deep digging to determine what other things were playing a role, from her stress situation, her emotional well-being, her mental health, her sleep. None of those pieces were addressed. And they did not take into account the full picture of male factor that was playing a role. So even though her husband's initial seminal fluid test done was normal, there were some other abnormalities that needed to be worked on as far as his overall health as well. So let's talk a little bit as far as normal fertility statistics. So this is going to be in couples with normal fertility, meaning that neither of the partners have any issue with fertility. And so again, we go back to that 1 year without pregnancy is typically the standard evaluation timeframe. What we know is that in each cycle with normal fertility, pregnancy will occur in about 25 to 30% of cases if everything is normal. Even if things are optimized, still only happens 25 to 30% of the time. So, if fertility is normal and you know when you're ovulating, we know that approximately 95% of couples or more will be pregnant within a 6-month time frame. And so this is part of the reason that I shorten down that window and say if you've been trying for 6 months or more and have not been able to achieve a pregnancy, that's when the best time is to get evaluation. Again, that statistic of 1 in 6 couples will be faced with fertility struggles in their lifetime also plays a role here. So, how do I know if I have fertility problems? How do I know if I'm 1 in 6? So, my recommendation is that if you know when you're fertile, so I've identified when you're ovulating, you know your fertile window, and you're not getting pregnant within that 6-month time frame, that's the time to start that evaluation because we know that 95% of couples will be pregnant within 6 months if everything is normal. If you're not pregnant within that 6-month time frame, most of the time there is an underlying factor going on that needs to be evaluated. Do fertility problems run in families? I get asked this a lot, and there are certain genetic conditions that can predispose you for having fertility issues. Typically, these are going to be related to a particular diagnosis, which is why it's so important to know exactly what it is that you're dealing with. So, different diagnoses like PCOS, thyroid dysfunction, autoimmune disease, diabetes, and other medical conditions can make it more challenging in order to get pregnant. But again, it's important to know what your unique diagnoses are because not every family member will have those same diagnoses and every situation is unique. And then I wanted to talk just a little bit about secondary infertility. And I mentioned this earlier on, but secondary infertility happens when you have been able to achieve a pregnancy and then you go on to try and achieve a second pregnancy or more down the road. And 10 to 15% of the time, people will have troubles getting pregnant a second time. And this may be a second or a third time down the road, but basically, if you've had a successful pregnancy in the past and then you try and achieve pregnancy, 10 to 15% of the time, you're going to be dealing with secondary infertility. So all of these situations are going to fall under what we're discussing here today. So whether you're dealing with primary fertility concerns, whether you have familial or genetic reasons for fertility, or whether you have secondary infertility, all of this is going to be addressed and encompassed by what I'm talking about next. So what are some ways that I can prepare for pregnancy? The number one thing that we recommend to women is to learn how to chart your cycles. This is so incredibly important because if you don't know or can't identify when you're ovulating and when your fertile window is, it's really hard to just take that by chance. And so you'll be able to tell if you know exactly when you're ovulating, when that fertile window is, you can time intercourse during that time frame in order to help improve your chances of achieving a pregnancy in that cycle. The other thing that's important to do is make sure to check in with your primary care provider or your OB about your prescriptions and supplements. Oftentimes, there are certain meds that are recommended to stop even prior to getting pregnant. And so it's important to work through tapering off any medications that aren't absolutely necessary. If you haven't had labs done in a while, you may want to consider getting some baseline labs checked. Things like your vitamin D and iron counts are important to make sure that your stores are well boosted prior to pregnancy because baby is going to need lots of that while you are pregnant. It's also a good idea to check your blood counts and a complete thyroid panel to make sure that everything there is looking to be in good shape. Again, we're looking to optimize things ahead of time so that we can hopefully prevent any problems down the road. If you've picked up some bad habits over your lifetime, so if you are somebody who is smoking, using recreational drugs, or if you're consuming a larger amount of alcohol or caffeine, this is a good time to cut back or eliminate altogether on those things. Anything we can do to improve your health during this time is also going to improve your chances of being able to get pregnant and help improve the health of the baby. The other ones that are listed here are sometimes the most challenging things, and these are going to be lifestyle management. So improving your sleep, making sure that you're trying to get that good minimum of 7 to 8 hours of sleep per night, managing your stress levels, learning to say no, maybe backing off on some of the excess projects or taking on that extra thing that you normally would say yes to. This is a good time to kind of back off, decrease those stress levels. Also, a great time to check in on your diet and activity level. Now, it's important to make sure you're getting plenty of whole foods, trying to avoid processed foods, but we don't talk about necessarily going on a diet. I want to make sure that it's something that's able to be sustained. And so, really getting a good variety of healthy proteins, lean meats, good healthy fats, plenty of fiber in your diet, fruits, veggies, all of that good stuff. Not limiting or eliminating any food groups necessarily, but just making sure we keep a nice balance. And then the final piece on here, as far as preparing for pregnancy, if you're not exercising, the recommendation is to get up and get moving a bit more. Now, this doesn't have to be marathon training, but even to say I'm going to walk 15 to 20 minutes a day, that is an adequate amount to get moving. If you're somebody who is very intensely exercising, it's a good time to start and back down on that a bit. We know that excess exercising can actually lead to increased cortisol levels, increasing your overall physical stress, which actually can prevent ovulation from occurring and make it more challenging to get pregnant. So again, any of these things in moderation, but also just getting a really good idea for where am I at, where can I make some of these changes along the way. When it comes to supplements, my general philosophy is less is more, especially when it comes to pregnancy. So really, we want to limit this to just a few good things. So a good quality multivitamin or prenatal vitamin if you are not already getting an adequate diet. If your diet could be a little bit better, if you don't eat much for fruits and veggies or calcium, it may be good to add in a prenatal vitamin. Many of the good quality prenatal vitamins also have methylfolate in them. And so if you're not doing a prenatal vitamin or if it's not already in your prenatal, you want to be making sure to get plenty of methylfolate. Now, the recommendation for methylfolate basically replaces the old recommendation for folic acid. Methylfolate is a similar substance to folic acid, but it's absorbed better. And for people who may have MTHFR mutation, the methylfolate is the version of folate that can actually be absorbed. So in general, we recommend if you don't know if you have MTHFR or if you're concerned about your ability to absorb it, methylfolate is really going to be your best bet. And again, it's already in many of the good quality prenatal vitamins that are out there. Another one that's really important is fish oil or omega-3s, those good healthy fatty acids, aiming for a minimum of 700 EPA daily. Now, if you get enough of this in your diet over the course of a week, that's fine. Where we live here in the Midwest, it's really hard to get good quality seafood that's fresh. And so oftentimes that supplementing with the omega-3s becomes incredibly important. And then vitamin D3. I cannot stress enough that everybody needs to be sure that they have adequate vitamin D levels. And if you need to supplement, we want to add in that K2 along with it for better absorption. Now, oftentimes you can find vitamin D that has K2 with it already, and that helps to improve your absorption levels. So that way you actually get that vitamin D3 into your bloodstream where it needs to be. And then any other supplements beyond that are really going to be just specific to your lab results. So really, if we look at it, there's going to be just three. So your prenatal vitamin with methylfolate, omega-3, and vitamin D, and that's it. Anything above and beyond that oftentimes is not necessary unless you have been recommended by a healthcare professional specifically to take something else. Beyond that, we want to get rid of all of the excess stuff. There's so much other things that are in a lot of the other supplements that can actually impair hormone formulation, block ovulation, and we don't know consistently what a lot of supplements do. So best to just work on getting rid of anything that is not on this list. So let's go back just a little bit to some basic concepts about fertility. And I know this takes you back to those puberty talks that you had when you were younger, but really when it comes down to it, fertilization requires just three things: egg, sperm, and then cervical fluid or cervical mucus in order to allow that sperm to transport where it needs to go. So in general, men are always fertile after puberty. Sperm are produced and available 24/7, 365. And sperm can survive for up to 5 days in the right conditions. So, if they're in a good quality mucus environment, if there is no other issues as far as pH imbalance or infection or anything like that, sperm can survive for up to 5 days. Now, on the flip side of things, women are not always fertile, and that fertility depends upon the time of ovulation around when the egg is actually released. And generally, that ends up being a window of time for a total of about 5 to 6 days each cycle. Now, peak fertility is going to be around the time or the day of ovulation. And then generally, we say 1 to 2 days prior to and after that ovulation day is going to be your best chances of fertilization. And so, when we talk about timing for intercourse, again, we want to target that fertile window. So whenever you notice that cervical mucus is present, that's going to be your fertile window. And that's the time that if you're trying to achieve a pregnancy that you want to aim for. During that fertile window, the recommendation is to aim for having intercourse every other day. Now, some people come in and they say, we're going to make sure that we have intercourse every single day. And that's not necessarily wrong, but we can find that sometimes that doesn't allow enough time for sperm to regenerate. And so timing things every other day actually will improve sperm counts during that time frame. It also improves the quality of sperm. So perhaps every other day is better during that fertile window. Another thing that's really important is that you should avoid most over-the-counter lubricants because many of them are petroleum-based. Now, that petroleum base in many lubricants can actually impair the movement of sperm and can actually damage them so that they don't have the ability to get to where they need to go to that egg. If you need to use a lubricant, it is okay to use a water-based lubricant. And one of the favorite brands that I recommend is called Pre-Seed, and it is available over the counter. Now, this is an example of just a charting situation, and I don't expect for you to learn or understand or fully know what's going on with this chart, but I did want to call out a couple pieces here as far as how charting works. So what we see, and I'm just going to orient you here, this first day, day 1, that is the first day of this woman's menstrual cycle. So the first day that she had any actual bleeding. As we go forward here, you'll see each of these boxes is annotated by a certain day, and each of the days along here is a different day of her cycle. So we can see that for the first 7 days of her cycle, she did have some red bleeding, and that's her menstrual flow. After that point in time, she had a couple of days that were dry as far as her mucus observations. So she didn't observe any cervical mucus or cervical fluid. Then she went on to develop some mucus that happened here. And so she went into this patch of 6 days where she observed cervical mucus. Now, these observations are not an internal examination. This is just the external examination that she notices when she goes to the bathroom and when she wipes with tissue paper. This is not what we see on our underwear. This is completely an internal mucus that is being presented on the outside of the body with wiping. And so this helps to determine this is when this woman's fertile window is. So she was trying to achieve pregnancy, and so she utilized these days during her fertile window in order to achieve pregnancy. We can see that marked down here. These are the days that they had intercourse. And again, they did utilize every other day during that fertile window and continued a bit past it because we know that the fertile window actually extends for about 3 to 4 days even after ovulation because again, that's how long sperm can survive. Now, this particular chart also shows a couple other things, and I want to just call that out because some people are charting their cycles using different tools. So the primary one that we recommend is just through cervical mucus observations. It tends to be the most easy, it tends to be the most reliable, and we're able to see cycle after cycle how that changes. However, you can chart other things like your basal body temperature, and so that's annotated here by this graph that you can see. And what we know is that once you've ovulated, your basal body temperature actually will increase a bit. So you don't necessarily know that you're in that fertile window at the time, but once you see that temperature shift, you can be sure that you have ovulated in the time leading up to that. And so temperature becomes a reliable method if your basal body temperature is fairly equal. Now, in this particular example, her temperature was kind of all over the map, so it may not have been the best indicator. So it was good that she was also using this cervical mucus for observation. There are many different devices available out there now that can help to monitor your basal body temperature. And I would just caution that they are not a complete way to track your fertility and to know what's going on with your cycle, but they can be used as a tool in order to help determine sometimes what's going on and in conjunction with an actual charting method. The last piece that I want to point out on this is that this particular individual did end up also using urinary LH monitoring. And so she was able to enter in her results here, and so was able to see that when she had this LH surge, it did align with within 24 hours of when she had her peak day of her mucus observations as well as her temperature shift. So this is a great example showing there's many different ways that you can track what's going on with your cycles in order to be able to have a better understanding of when you're fertile. And again, this is a very normal chart. So not all charts look like this. And that's why it's so important to work with somebody to learn how to chart your cycles, to know what's normal for you. So I like to show this as well. This is just that same chart along the top so you can see day after day what's going on. But underneath here, you can see from a physiologic standpoint what's happening on the microscopic level. So on this first line here, this is what's going on at the level of the ovary. And so we can see this teeny little blue dot in the middle, and that's going to be the egg that's developing. Now we have around it what's called a follicle, and that follicle over time starts to grow bigger and bigger as it's preparing for ovulation to occur. At the time of ovulation, we call that your peak day or the day of ovulation. Then that follicle opens or ruptures and it releases that egg to go on and become fertilized. That follicle then stays on and continues and turns into what we call the corpus luteum. Now, if you are pregnant, that corpus luteum is one of the first things that sets up shop for helping to recruit progesterone and estrogen to help with the developing placenta. If you're not pregnant, that corpus luteum actually will start to shrink down in size, and then when pregnancy is not happening, it will actually go away completely and be gone by the next cycle. And oftentimes when women have an ultrasound done, they may be told, oh, you have an ovarian cyst. That cyst could just be this follicle, which can be completely normal. Depending upon where they're at in their cycle, that cyst may be this corpus luteum, again, which can be totally normal. So not all ovarian cysts are abnormal. And in fact, it is incredibly normal and necessary to see this developing follicle, especially if we are looking for fertility. The other piece, as far as hormones go, that we can see is that we see that this hormone line of the estrogen or the estradiol is going to shift and increase leading up to ovulation. Then when ovulation occurs, there's generally a pretty significant drop in estrogen. It increases again for a little bit before dropping off. The other hormone line that I want to show you here is this progesterone. And so progesterone typically early in the cycle is going to be very low, very flatlined. But after ovulation, progesterone really starts to take off, and then it should peak somewhere around 6 or 7 days after ovulation has occurred. Now, this is why it's so important to understand what day exactly you ovulated, because when we're timing your lab draw, that day of ovulation may be different from cycle to cycle. So if you ovulate on day 7, when we check your labs, we need to know that when that ovulation happens, and a week after ovulation is when your progesterone should be at its highest point. So this is what allows us to really be able to track with very, very high level of precision where your levels should be at any day in your cycle, is if we're identifying this ovulation day. The last couple of pieces down here show what happens with your cervical mucus as you're approaching ovulation. So typically cervical mucus very, very low prior to ovulation. And then as we get closer to that ovulation event, your cervical mucus gets very stretchy. It sometimes will stretch even up to 2 centimeters or more around the time of ovulation. And then after ovulation is done, the cervix starts to close, and then that cervical mucus will start to decrease again. And then in the very bottom graph here, this one shows what's happening with your basal body temperature. So again, typically you'll have things fairly flatlined, fairly level. And then once ovulation occurs, then you generally will have this spike in your temperature. And if you are pregnant, that temperature actually will stay elevated. If you're not pregnant, then oftentimes that temperature level will drop in preparation for getting ready for the next menstrual cycle. So, a lot going on here from a physiology standpoint and hormones and mucus cycle and temperature, but we can really summarize and understand all of this from a timeline of knowing what's happening with your charting. And that's why it's so incredibly important to have that chart so that we don't have to check labs every single cycle. We don't have to know what's going on with my temperature and see what the ultrasound is doing every single cycle. We're able to infer that based on what we see from that charting evaluation. So here's a couple examples of some charts showing infertility. Now, this is basically similar to the last charting example, other than this is a different method. So this method is called Creighton model, whereas the last method, it was called Chart Neo or Neo fertility. So this particular charting method called Creighton model is similar in that you're going to identify your days of bleeding, you're going to identify your dry days, and these are the green days, and then days of fertility are marked with this white baby stamp or the green baby stamps, and this shows you where your fertile window is here. So in this particular example, this person has a fairly normal 28-day cycle, but she has very limited mucus. Now, she could still get pregnant if she knew exactly when her time of fertility was, but it's going to be much more challenging to achieve a pregnancy with a more limited cycle here. This next cycle actually looks fairly normal, and we do see that she has some good days of some fertile mucus leading up to it. However, we see that, things, even if they look normal, can show that people have a hard time getting pregnant. And so this is a great example of, hey, we have to dig a little bit deeper. This next line here shows a good example of somebody who is not identifying any type of cervical mucus, and thus it's really hard to know if she's ovulating or not. So we can see this in cases of anovulatory cycles, or she may still be ovulating but just not have any fertile mucus that's there, which means that it's going to be incredibly challenging to get sperm where it needs to go. Again, we need that cervical mucus present in order to allow that good transportation of sperm to get to the egg. The next line here, line D, is an example of a woman that has what we call a short luteal phase. And so initially it looks like she has a pretty good mucus patch leading up to here, but then what happens is that she has her menstrual cycle start after just 23 days. Now, a 23-day cycle isn't always a problem if you way back here. However, because she ovulated here on day 18, that means she only had 5 days from when she ovulated until her next menstrual period started. And what this means is that that's not enough time for implantation to occur. So even if fertilization was happening, implantation is going to be incredibly challenging because there's not enough time for her body to recognize that she's pregnant before that next menstrual cycle begins. Now, oftentimes women may not even know that they're getting pregnant in these situations because their period has already started before they would even check a positive pregnancy test. So these are just some examples of infertility situations. It doesn't explain everything that's going on, but I also like to just show that sometimes things aren't always what they seem, and we need to dig a little deeper when it comes to the charting. So what causes fertility problems? Again, as I had mentioned earlier, about a third of the time we know female factor alone. So there's lots of different things that can cause this, whether it's troubles with the egg, ovulation itself occurring, if there's hormone imbalance, vitamin deficiency, or there may be anatomic issues, things like endometriosis or an unusual shape of the uterus. Maybe there's a blockage of the fallopian tubes. Lots of different things to think about when it comes to female factor. However, approximately equally as often, a third of the time we find that there can be male factor. Now, this can be from that initial seminal fluid analysis, so we may find decreased sperm counts, decreased motility, decreased morphology, or sometimes we see that all of that looks to be okay, but there's actually just poor quality of the sperm. So the only way that we can know this is that we do a specialized test called a DNA fragmentation index, and that looks for the actual quality of the DNA of the sperm itself. If we do just that seminal fluid analysis, that is not enough to just check the box and say everything is good. Sometimes we have to dig a little bit deeper to know and understand if there's another male factor that's playing a role. And then, unfortunately, a third of the time, we can have problems with both partners where there may be some overlap of both male and female factor. Another thing that can happen is in this LAD testing. And so we call that leukocyte adhesion deficiency. And what happens is that when egg and sperm meet, there needs to be this immunological spark that occurs. That spark helps to tell the woman's body, hey, something is going on, something is different, and I need to prepare for implantation to occur. And so if there's not this spark that occurs, immunologic standpoint, when egg and sperm unite, that can actually prevent fertility and it can prevent a pregnancy from occurring. And so that is a factor. It's not incredibly common, but it is important to know about and it is important to test for because there are things we can do to help correct that if we find that that's an issue. So again, lots of different things that can cause fertility problems, and sometimes it's really challenging to know where to start, especially when you can have some overlap. And one of the things that I always reassure my clients is that we don't have to fix 100% of the things. It can feel like this huge load that you're carrying, especially if you come in and you get these different diagnoses and we say, oh my gosh, we found 15 things going on. We don't need to fix 100% of the things in order to be able to get pregnant, but we have to know what it is that we're treating. Because if you're just trying to force medications at this situation, then there is nothing that's going to fix that for the long term. And more importantly, we're not correcting any underlying health conditions that may be a cause for those fertility issues in the first place. So let's go back to Kay. Now that you have a little bit better background as far as what we need to be looking at, what we need to consider, and what's going on. So when Kay finally came to see us, we got her started with charting her cycles. She did take a break between her IVF sessions because she was just so overwhelmed with everything. And finally, a friend said, hey, I think you need to go talk to Dr. Minger. We need to get figured out what's going on because there's something here that's not right. So we started off getting her charting her cycles. And really, again, this is to identify, is she ovulating? Are we seeing a fertile window? And throughout the entire time that she had been working with her other provider, nobody had started her charting her cycles. Nobody had been evaluating if she was truly even ovulating or not, and what that looked like on a consistent and regular normal basis. After she was charting her cycles, we were able to order that targeted hormone and complete lab panel. And again, so incredibly important to make sure that we timed that appropriately. We generally will check early on in the cycle, somewhere between cycle days 3 through 5 as one set of labs. And then the second set of labs we do is going to be at 7 days after ovulation. And again, because that is when the highest point of her progesterone levels should be, we want to see what's happening post ovulation to make sure that her hormone levels are adequate enough not only to achieve pregnancy, but also to support a pregnancy and prevent miscarriage. We also ordered some timed ultrasounds to check follicle development. Now, Kay had some ultrasounds completed in the past when she went through some of her other treatments, but nobody had really checked and followed along with the follicles to make sure that the follicle was actually opening to release that egg later on. What had happened was that when she went through her IVF cycles, they tracked the follicle development, made sure that she had a whole bucket load of eggs, and then they went in for the egg retrieval. And so it was very different. Even though she had had an ultrasound done, it wasn't that follicular tracking scanning and then making sure to repeat that follicle scan after she had ovulated to make sure that that dominant follicle had opened in order to actually release the egg. We also repeated a hysterosalpingogram, and that's a test to check if the tubes are open. This is sometimes also called a dye test or a tubal patency test. Now, Kay did have that completed early on in her evaluation, but by the time she came to see me, it had been almost 4 years since it was done. And so we did repeat that test just to make sure that nothing had changed over time. And then we did also do the additional male factor evaluation. And so even though her husband's initial seminal fluid counts came back normal, we did go ahead and do that additional DNA fragmentation testing and found that there were some issues as far as the quality of his sperm. So separately from Kay, even, we talked through what does that look like for him, ordered some lab evaluation, had him start working with his primary care doctor to help improve some of the things with his overall health as well, so that we could improve the quality of the sperm as well. So, Kay's evaluation, what she had done previously when we reviewed all of her other records, she had these first six tests that were done. Those are all blood tests. So, TSH is a thyroid screening test, it is not a complete thyroid panel. FSH, or follicle stimulating hormone, was basically just looking to make sure she wasn't in premature ovarian failure. Estradiol, which is the primary source of estrogen for women who are having menstrual cycles, and then progesterone and prolactin. Now, importantly, none of these were timed with her cycle. They were all just drawn on what's called a cycle day 21 lab draw. And so sometimes these labs were very, very low. Sometimes they were normal. Sometimes they were higher than usual. But everything was reported out as quote unquote normal, because oftentimes the lab doesn't differentiate what should be optimal for certain phases of the cycle. The other lab test that Kay had done was an AMH, which is called an anti-Mullerian hormone. And this is oftentimes done in preparation for in vitro fertilization, because we want to make sure that those levels are high enough that stimulation from the ovaries is going to happen so that they can actually retrieve an egg. If AMH levels are too low, oftentimes they won't even go through IVF. And so again, Kay's AMH levels were normal, but it doesn't necessarily mean that there wasn't a problem, obviously. She also had those ultrasounds done, but again, the ones that we did were a bit different. So as opposed to what she had done previously, her evaluation with us, like I mentioned, was the timed lab draws at 2 different times in her cycle. The initial general profile that we look at checks over 20 different hormone levels, includes a complete thyroid panel as well as adrenal evaluation. We also evaluate vitamin levels, things like vitamin D, vitamin B12, iron stores. We make sure that those levels are optimized prior to pregnancy, because they can impair ovulation if the numbers are too low, but more importantly, they really impact the health of mom and baby, especially in that first trimester. We also assessed Kay for insulin resistance. Now, this is something that does not often get checked, and many women come to me, they've maybe had a blood sugar checked or an A1C checked, and although this can evaluate a blood sugar level, even before we see blood sugar elevations, we oftentimes will see that insulin is starting to creep up, and that can be from insulin resistance. And so it's incredibly important to check for insulin resistance, because it can impair ovulation function and implantation. And then the final piece, as I mentioned a couple of times now, is that we did do those cycle timed ultrasounds as well as hysterosalpingogram. Now, this is a lot of information. These are some of Kay's results from that initial set of lab testing. And it's not important. We're not going to go through each individual piece. But what I will call out here is that anything that is bold is something that is abnormal or not optimized for fertility. And so even though previously that her labs were all normal or everything looked fine on the 6 different lab tests that she had done, these are the lab tests that we did just on that first cycle day 3 of her cycle. And as you can see, there's quite a lot actually that was abnormal for her. This is the additional testing that we did 7 days after ovulation, is on the bottom. And then at the top, this is actually, we go through what's called a glucose tolerance test. And so what that is that we have her come in fasting. We have that first lab drawn, and then we have her drink a big old sugary drink. And then we check her blood sugar and insulin every 30 minutes thereafter. And what we find is that, as you can see with Kay, her blood sugar levels actually did pretty okay. She stayed within normal ranges. However, the insulin levels did take a significant jump, and some of them were even over where the levels should be, depending upon the timing of her cycle. And so we were able to find that she did have some insulin resistance, even though her blood sugar numbers were totally fine. So this is not diabetes. Some people may call this pre-diabetes, but the correct term is actually insulin resistance. And this is something that became incredibly important to restore. You can also see down here that the lab tests that were done after ovulation, all of these, none of them were within the normal range. So again, optimal for pregnancy, for example, for progesterone should be somewhere between 18 to 30. And for Kay, it was 7.2. Optimal for her estrogen should be between 100 to 250, and she was at 68. So again, even though the lab had said that these numbers are normal, it doesn't mean that they were optimized for Kay in order to go on and achieve a pregnancy. So, what did Kay end up having as far as diagnoses? So, this is where we talk about it's important to know what exactly we're treating. So, I diagnosed her with quite a few things here: ovulation dysfunction, a luteal phase defect, and that's what happens of that low progesterone and estrogen throughout the later part of the cycle. Insulin resistance. She also had some thyroid dysfunction. So even though her thyroid gland was okay, even though it was producing an okay amount of T4, her body was not able to take that T4 and convert it to T3, which is the active form that binds to the cells. So even though her thyroid was okay, because she couldn't get that active thyroid to the cells that function throughout the reproductive tract, she was still struggling with some thyroid dysfunction. We also diagnosed her with some adrenal insufficiency as well as a vitamin D deficiency. And so when it comes to treatment, now we have a great idea of what exactly we're treating, how to target each of those pieces. And so then we start to focus on treatment. And in general, I have three different mainstays we utilize for treatment. One is going to be lifestyle changes. So if there are pieces of her lifestyle that need to change, whether that's dietary recommendations, help with sleep, reduction of stress, dealing with mental health situations, making sure we're regulating exercise, lifestyle recommendations are always a part of our treatment plan. The next piece we always talk about is supplement recommendations. Now, there are oftentimes supplements that are specific to what we're trying to treat. Some of them are for general wellness, but again, we're trying to minimize excess number of supplements and really just utilize them in a way that targets what we're treating based on those lab results. There are also prescription medications that we use, and oftentimes those we utilize just to try and get things back on track. Now, there are certain times when prescription medications are necessary longer term, and oftentimes we'll see that in cases of thyroid dysfunction or in luteal phase defects. And really the idea is that we want to utilize those medications in a way that we're not over treating, but also that we're helping to bring those levels back up to optimal range. Most importantly, we want to make sure that we're targeting the treatments to her cycle. So, for example, if we're giving progesterone, we should only be getting progesterone in the later part of her cycle after she's ovulating. And so, because of that, we wouldn't want to give progesterone to be taken every single day. We say, hey, you're going to start your progesterone 3 days after you've ovulated, because that's naturally when your body would say we're going to be increasing those progesterone levels. So that's why it becomes incredibly important with that charting that we continue that, so that way we're able to utilize the treatments accordingly. Now, this is just an example of some of the specific treatments we utilize for K. And again, this is where that disclaimer comes in, that just because you have fertility troubles doesn't necessarily mean this would be your same treatment protocol. And in fact, even for people who have the same diagnoses that K has, doesn't necessarily mean we treat things the exact same every way. So Kay ended up with some exercise modifications as well as some dietary changes. I also started her on some supplements. She was quite deficient in vitamin D, so we added in vitamin D. We utilized some myo-inositol specifically to help with the insulin resistance as well as the ovulation dysfunction. We also started her on supplements for DHEA and adrenal support to help with the adrenal insufficiency that she was experiencing and that we saw based on her labs as well as her clinical situation. From a prescription standpoint, we added in letrozole. And the important thing about letrozole is that it is an ovulation stimulation medication, but it can be adjusted. So we don't go with always just this super high mega doses. We adjust it each cycle to make sure that we're not overstimulating things. We don't want to try and produce multiple follicles that are developing and causing ovarian cysts. And so we evaluate each cycle to make sure that the dosage is adequate. And we do that by rechecking a peak +7 lab each cycle. So 7 days after ovulation, we're repeating and checking again the progesterone and the estradiol levels to make sure that those levels aren't getting too high. If they're too high, then we decrease the dosage of the letrozole. If they're too low, then we sometimes will increase the dosage of the letrozole. So it's really important to make sure that we're monitoring this and not just saying, here, take this medication, come back in 6 months if you're not pregnant. But we do this active management. Kay also ended up on some HCG injections. And now this was not intended to trigger ovulation to make it happen. She actually was ovulating and was releasing and opening that follicle, which we were able to see on ultrasound. But the HCG injections helped to support both estradiol and progesterone production from that corpus luteum after she had ovulated. She also ended up on some metformin to help with her insulin resistance, as well as a prescription for a thyroid medication to help the particular type of thyroid dysfunction that she was experiencing. And again, as I mentioned, it's so important that we adjust those meds and supplements each cycle. So whether we're adjusting those for the results of the timed lab draws, whether we're evaluating and saying, okay, this is a lot of stuff, making sure we're not having side effects or issues or concerns, and making sure that it's something that is sustainable for Kay, not only financially, but that her body is handling and managing these medications and supplements well. And so in general, this approach that we utilize, it's called restorative reproductive medicine. And ideally what it does is we're utilizing that charting to evaluate the progress and assess concerns as they arise in real time. The difference here is that we're addressing the individual factors and diagnoses. So rather than having this diagnosis of unexplained infertility, we're able to really break it down and say, based on what's going on with your charting and your lab work, we're evaluating your individual situation and figuring out exactly what's going on. This allows me to create a unique treatment plan that it's created just for you. We adjust it each cycle if needed. And we utilize those lifestyle recommendations, which are so important. Most of my clients that I see don't want to be on a whole bunch of supplements and prescription medications. And so we're always talking about what are the different things we can do within lifestyle changes in order to make a positive impact and hopefully be able to get off of those supplements or prescriptions in the long run. The other important thing to note here is that with restorative reproductive medicine, we want to consider both the male and female factors. Now, oftentimes we start with addressing female factors because there's so much more to evaluate with that. But it's important to keep in mind that male factor does play a role in at least a third of the cases. So we always want to be mindful of that and keep that in mind. So in general, what does it look like if you decide, hey, I think this restorative reproductive medicine approach is important and this is the way I want to go? And so in general, the first stage, we call that phase 1, is the charting and evaluation stage. And typically what this looks like is that we get you working with one of our charting instructors to actually start charting your cycles. Start identifying, do I have a fertile window? When is it possible to get pregnant? When am I ovulating? And then we also will do that initial evaluation with me. And that's going to include that initial visit, ordering your lab work, evaluating what's going on, and figuring out what your actual diagnoses are. Then once we have a diagnosis, we have all of your lab work, we move into phase 2. And this is more that fine-tuning stage. So we're starting treatment course, we're adjusting the medications, adjusting supplements, and getting everything to the point of where we say it's just right. Now, for some people, this happens after just a month or so. For others, it can take 4 to 6 months. And so phase 2 is really variable in time. But in general, most people, we get through phase 2 within 2 to 4 months. And again, that's just that fine tuning, making sure that you're handling your therapy okay, as well as making sure that the lab results are looking good and that your charting is also starting to look more normal, especially if things were a bit irregular from the start. After that treatment and adjustment phase, we move into phase 3. And this is sometimes the most challenging phase because this is where we say, take off the intensity, try and decrease the stress levels when it comes to all of this. We're going to just continue what we're doing, but we're just going to observe and let things happen naturally. Now, this time frame can be anywhere from 1 to 12 months, but what we find is that most people will achieve pregnancy somewhere around 6 to 8 months into phase 3. Again, we've already gone through the charting, the evaluation, the fine-tuning, and that's where we say, okay, that's at phase 3, things are now back to baseline, what would be normal fertility. So if you think back to initially when we started this talk, and I said it can take up to 6 months for many couples to get pregnant, and that's part of where this timeline comes in. And so realizing that for many people, they've been already on this long journey of fertility struggles, but it can take some time to figure this out and get it right. And so the case that happened with Kay is that she was able to achieve a natural pregnancy with going through this process of restorative reproductive medicine about 9 months after starting care with our clinic. Now, did she want to achieve pregnancy within a month or two? Absolutely. But ultimately, we were able to get to the bottom of the cause of what was going on, figure out that root cause, address those concerns, and help her to go on to achieve that natural pregnancy. So, just an overview then, again, as far as the standard treatment that Kay was provided: 30 months, more than $47,000, and no real answers for infertility. Again, she had significant side effects from the excessive meds, ovarian hyperstimulation, as well as just the significant emotional distress of going through all of this. And at the end of it, had a diagnosis of unexplained infertility and no baby. Versus when she came to work with our clinic, she worked with us for about 9 months. Her total out-of-pocket cost, including medications and supplements, was about $6,000. More importantly, we had answers to why she was having fertility struggles. We were able to provide targeted treatments with those frequent medication adjustments. We were able to find at least 6 different new diagnoses to explain what was going on. And she delivered a healthy baby girl full term at about 7 pounds and 4 ounces. And most importantly is that if she wants to go on and have another baby, we have the ability to treat again because we have now determined we know what's going on from a diagnostic standpoint. We also know what has worked for a past pregnancy. And so it's really imperative to have those answers as to why in order to be able to move forward for her next steps. So, what are your next steps? First and foremost, if you're not already charting your cycles in a way that evaluates when you're ovulating and what your fertile window is, you need to learn a fertility awareness charting method. We have amazing charting instructors that work with our clinic, for our clinic, as well as other resources if you're not going to work directly with our clinic. But I would love to get you in contact with somebody who can help to walk with you as you start to learn how to chart your cycles. It's not always straightforward. Sometimes your charts look like a big mess. And so having somebody to talk through that process with you and really help you to understand when you're fertile as well as when you're not fertile can be incredibly important. The other great thing about fertility awareness charting is that once you know when you're fertile, you can also use that same mentality in the future if you're trying to avoid pregnancy. So because you know when you're fertile, you also know when you're not fertile. And so basically you would just avoid intercourse during that fertile window in order to avoid a pregnancy. So you can utilize this charting method for the rest of your reproductive days, which is really great. The other thing you can do is you can schedule a free discovery call with me. I'm happy to talk through any of your questions that you have. I don't offer direct medical advice, but we can talk through how our program would work best for you in order to help you to understand what your next steps are. We can also get you scheduled for free discovery calls with any of our hormone coaches or health coaches if you want to learn more about how those services may benefit you. And if you're not already doing so, follow our podcast. It's called Cycle Wisdom. I put out weekly podcast episodes, and they're typically fairly short, usually 15 to 20 minutes, and we discuss a different topic each week. And so oftentimes I talk about just general menstrual health things that apply to fertility, but sometimes we talk specifically about fertility, or what does it look like if I have PCOS and I'm trying to get pregnant? What does it look like if I've had recurrent miscarriages or postpartum depression? Or maybe I'm dealing with severe PMS, or maybe there's a teenager in my life who is dealing with really painful, heavy periods or symptoms. We talk about all of this and so much more on our podcast. So I would love for you to join us there at Cycle Wisdom. Here is a QR code that you can scan to learn more and stay up to date as far as what's going on with our clinic. So if you scan this QR code, it will take you to a Linktree link, and you'll be able to, from there, book that free discovery call with me. You can learn more about how to follow us on social media. You can find our podcast, and you can also sign up for any upcoming events that we have. So I would love the opportunity to be able to work with you, to chat more with you, and I so appreciate you spending some time with me here today. If this was helpful, please feel free to reach out, let us know, send this on to a friend, make sure that everybody in your life has this information who needs it. You can also connect with us directly at our website, radiantclinic.com. There is a section there where you can send in questions if you have specific concerns, if you want to talk more about knowing what are my next steps, or to schedule that free discovery call directly from there. So thank you so much for your time. I look forward to meeting you, to working with you, and to chatting more with you on discovery calls and in the future.